All right, welcome to my channel. This is Patrick. I finished my surgery clinical rotation, and in this video, what I'm gonna do is present interesting cases that you're likely gonna see during your surgery clinical rotation, and these are cases that are likely gonna show up in the exam as well. I have to inform you that this is not absolutely comprehensive, but it does cover quite a lot of cases, especially in the GI. All right, very important and very beneficial. So how the presentation is set up is that I'm going to go through the clinical cases and we're going to figure out together how to diagnose it as well as how to treat it. All right, let's go. So here we have a 63-year-old male who has difficulty swallowing solid food. He also has bad breath, which we call halitosis, and he regurgitates chunks of food after eating. All right. So when you're going through this clinical vignette, there are things, differentials at this point should be popping up in your head, right? Look at the age of the patient, very important. You look at what they're complaining of. So this patient has dysphagia, which is difficulty swallowing solid food, also has bad breath, as well as regurgitation. So question is, what is the most likely diagnosis? And then the next question is, what test can you order to confirm the diagnosis? And then how do you treat it? So let's find out. So this is zenker diverticulum. All right. So likely going to present with difficulty swallowing solid food, and a very important clue is the bad breath and then regurgitation. So we know what it is. Then how do you confirm it? The best test for confirmation of zenker diverticulum is barium swallow. And then in terms of treatment, you want to do surgical excision, which includes basically the removal of the cricopharyngeal muscles. They cut it out. Next, we have a 43-year-old male with a history of arthritis, and he smokes for the past 13 years. He is now presenting with epigastric pain an hour after eating. He's also reporting weight loss and hematemesis. Hematemesis is vomiting out blood. Vital signs are unremarkable, except that this patient is hypotensive, right? Blood pressure is 90/50. So what is the most likely diagnosis? What is the initial management of this patient? How do you confirm the diagnosis? So let's go back to this case. There's a history of arthritis, which means that this patient is likely having lots of pain, and they're probably taking a lot of pain medication like NSAIDs, right? And number 2 clue, this patient has been smoking for the past 13 years, right? And they're having epigastric pain. There is weight loss and very important hematemesis. So this is screaming peptic ulcer disease. And that's what it is. That's the most likely diagnosis, PUD, peptic ulcer disease. The initial management is you want to give IV fluid, you want to do NG tube placement, and then you want to put these patients on proton pump inhibitor, such as omeprazole. And then you can add broad spectrum antibiotics, and then ultimately you want to consult surgery. The way to confirm peptic ulcer disease is upper endoscopy. Number 3, what is the most common complication of peptic ulcer disease? And then what is the difference between duodenal ulcer versus gastric ulcer? What is the most common upper GI bleed? Let's find out. So the most common complication of peptic ulcer disease is bleeding, right? That's the most common complication. In terms of the difference between duodenal ulcer and gastric ulcer, and they're going to ask you questions in the exam, and they expect you to know the difference. So when you're taking that exam, you might even know that, okay, this patient has peptic ulcer disease, but you get confused. But what kind of peptic ulcer? Is it duodenal? Is it gastric? So here is the key difference. In terms of duodenal ulcer, it's going to tell you that the pain gets better when they eat. So the pain is alleviated after eating. However, gastric ulcer, the pain is worse when they eat. So the most common cause of upper GI bleed is peptic ulcer disease. Moving on. What are the two most common causes of peptic ulcer disease? This is also very high yield. How do you confirm that you have eradicated H. pylori infection? What are the signs of upper GI bleed? Now, you confirm that a patient has H. pylori infection. You do that by doing endoscopy with biopsy. What is the most appropriate treatment? So let's go one by one. The two most common causes of peptic ulcer disease are H. pylori infection as well as NSAIDs. Okay, and when it asks you the most common, it is H. pylori. And in terms of how you confirm, so normally you do eradication test. Anytime you treat somebody with peptic ulcer disease and they have H. pylori, they are supposed to come back and you do eradication test, a test that confirms that indeed this patient no longer has the H. pylori infection. You do that by doing the H. pylori fecal antigen test. And I got a question on this. So in terms of the signs of upper GI bleed, you're probably going to see the description that the patient has bright red emesis, or they're coughing out what they describe as coffee ground emesis. They're likely going to present with epigastric abdominal pain, and they're likely going to be hemodynamically unstable. So after you have confirmed by doing an upper endoscopy with biopsy that this patient has peptic ulcer disease, the most appropriate treatment is what we call the triple therapy. And this consists of clarithromycin, amoxicillin, as well as omeprazole for 2 weeks. Next, we have a 56-year-old male presenting with abdominal pain that radiates to the back. He also has foul smelling and greasy stool. You now do a CT scan and you're seeing calcification. What is the most likely diagnosis? How do you treat the above diagnosis? What are the causes of the above diagnosis? And what are the complications of chronic pancreatitis? I didn't write this question well. I ended up giving out the answer, right? So the most likely diagnosis is chronic pancreatitis. And there is a distinction here between chronic as well as acute pancreatitis. And in the subsequent slides, I'm going to elucidate on this. So in terms of how you treat the above, you want to do, first of all, it's important to know what causes it. The most common cause of chronic pancreatitis is chronic alcoholism. So you want to stay away from the most common cause, right? Obviously, you want to stop taking alcohol, right? And then you manage the pain that the patient presents with, okay? In terms of what are the causes of the causes of chronic pancreatitis, as I already mentioned, the number one is chronic alcoholism, and the next one is gallstone. Okay, stones that form in your gallbladder. Okay. And we'll talk about the complications. Again, the most likely diagnosis of this case is chronic pancreatitis. Treatment includes lifestyle changes such as stopping alcohol, all right, and tobacco, and then pain management. The most common cause, like I mentioned early on, is alcoholism, followed by gallstone. Now, if you contrast chronic pancreatitis with acute pancreatitis, you realize that the differences, that the causes switch up. In terms of chronic pancreatitis, the most common cause is chronic alcoholism, followed by gallstone. However, in acute pancreatitis, the most common cause is gallstone, followed by alcoholism. So now let's look at the complications of chronic pancreatitis. You're going to see things like pancreatic pseudocyst. You're probably going to see glucose intolerance and malabsorption. And you can see things like steatorrhea, which is foul-smelling and greasy stool. Next, we now have a 33-year-old male presenting with rectal bleeding, which he notices occasionally when he is constipated. He describes the blood as bright red on toilet paper after bowel movement. Physical exam shows purplish bulges in the front of the rectum, and he denies pain. What is the most likely diagnosis? What is the first line treatment? And what are the risk factors? So let's dissect this case a little bit more. The age is 33. This patient is male, presenting with rectal bleeding, which happens episodically, right? It doesn't happen all the time. It happens occasionally when he's constipated. He describes it as bright red blood on a toilet paper after going to the toilet, after a bowel movement. Upon physical examination, you are seeing a purplish bulges in the anterior part of the rectum. What is this? This is screaming hemorrhoid. What is the first line treatment? You want to do things like seat baths, right? So let's find out. Let me not be ahead of myself, right? The most likely diagnosis is hemorrhoid. First line treatment includes increase in dietary fiber. You need to increase fluid because constipation is a risk factor, and you want to do seat baths. So in terms of the risk factors, again, I mentioned it, constipation. These patients are always straining, and then you have advanced age and pregnancy as well. Okay? So what are the anatomical locations of internal versus external hemorrhoids? I got a question on this. How do you treat internal hemorrhoid that does not respond to conservative treatment? Then describe the 4 grades of internal hemorrhoid. So in terms of anatomy, internal hemorrhoid is located above the dentate line, while external hemorrhoid is located below the dentate line. You are going to get a question on this, almost guaranteed. Also, external hemorrhoid are usually described as exquisitely tender. So when you palpate an external hemorrhoid, you are likely going to elicit pain versus internal hemorrhoid, which is typically non-painful. If internal hemorrhoid does not respond to conservative treatment, at this point, surgery is indicated, and that involves what we call rubber band ligation. I also got a question in terms of being able to know. They're going to present a case to you, and they're going to want to know what grade of hemorrhoid It is. So in terms of grade 1, it does not protrude through the anus. In terms of grade 2, it prolapses but reduces spontaneously. Grade 3 prolapses but requires manual reduction. Grade 4 cannot be reduced. And there's a high risk of strangulation. So you need to understand that. Very important. Next, we have a 60-year-old patient who is presenting with right upper quadrant abdominal pain. There's jaundice and there's fever. Labs are elevated with white blood cell count, bilirubin, AST, as well as ALT. I also got a question on this. So this is a charcoal triad where you have right upper quadrant abdominal pain. You also have jaundice and fever. When you're reading a case and you see 3 of these mentioned in that clinical vignette, this is cholangitis until proven otherwise. It's called the charcoal triad. Right upper quadrant abdominal pain, jaundice, as well as fever. If you now see hypotension, as well as altered mental status, that is called the pentad triad. So the next question is, you know that this is acute cholangitis. How do you treat it? What is the most common cause? And what is the imaging test of choice? Let's find out. So like I mentioned previously, the most likely diagnosis is cholangitis, which is infection of the biliary tract, and this can lead to obstruction. In terms of treatment, it is biliary drainage as well as IV piperacillin tazobactam. I spelled that wrong. The most common cause is cholecystolithiasis, which is gallstone in the bile duct. I always struggle to pronounce that correctly, but I'm getting better at it. Cholecystolithiasis. The initial imaging study is ultrasound, and the gold standard is ERCP. It is both diagnostic and therapeutic. Next, we have a 60-year-old patient who is presenting with right upper quadrant abdominal pain that radiates to the scapula. There is tenderness and palpation of the abdomen. And when there's deep pressure applied to the abdomen, there is pausing in terms of inspiration. The labs show normal liver function tests, but there is leukocytosis. So again, when you're reading clinical cases like this, you have to highlight things that are important. As my professor always used to say, the answer is always in the question. So there's right upper quadrant abdominal pain. It doesn't stay there. It travels to the scapula. And then when you palpate the abdomen, there is halting in inspiration. So the patient stops breathing, right? And then when you do the lab, the liver function tests are fine. But you notice increase in white blood cell, which is leukocytosis. So this is cholecystitis. And how do you treat it? What is the most common cause? And what is the imaging test of study? So let's see. So the most likely diagnosis is cholecystitis, which is inflammation of the gallbladder due to gallstone. Treatment includes you want to put these people NPO, which is nothing by mouth. But when you put somebody NPO, you can't keep them, you have to give them something. You give IV fluid. Then you have to give antibiotics, such as ceftriaxone or piperacillin tazobactam, and ultimately, you want to do cholecystectomy. All right? Which is removal of the gallbladder. Then the most common cause is gallstone, obstruction by a gallstone. Then the initial imaging of study is ultrasound. I got question on this. And let me say it. If whether you're dealing with cholelithiasis, cholecystitis, choledocholithiasis, okay, or cholangitis, the initial study, imaging study, is ultrasound. Then, in terms of cholecystitis, if you still have questions or ultrasound does not elucidate the diagnosis, you then want to get a HIDA scan. That is the gold standard. All right, next question. We have a 40-year-old patient who is presenting with right upper quadrant abdominal pain with nausea and vomiting. There is tenderness and palpation of the abdomen, and you notice jaundice. You do lab, and you see this elevation in transaminases. There is also increase in bilirubin and GTT. What is the most likely diagnosis, and how do you treat it? What are the complications, and what is the imaging test of study? So let's go back to this. We have another case of right upper quadrant abdominal pain, but now we have nausea and vomiting. There is tenderness upon palpation of the abdomen, and you notice jaundice. Pay attention. In this case, we have elevation of transaminases, bilirubin, and GTT. So this is choledocholithiasis. And sometimes they can present it, in the case, they can say things that, oh, they did an ultrasound, they see a dilation of the common bile duct. There are so many ways they can present this, but it is important because you are going to get a bunch of questions on the C's. I call them the C's: the cholelithiasis, the cholecystitis, the choledocholithiasis, the cholangitis. You have to be able to be comfortable in knowing the subtle differences between these four guys. Because you are going to sit in that exam hall and you are going to be wondering, looking at the ceiling, wondering, is this cholecystitis? Is this cholangitis? Is this choledocholithiasis? So just to recap again, cholangitis, I'm looking at right upper quadrant abdominal pain. I'm looking at things like jaundice and fever. Okay? I'm also looking at hypotension. I'm asking myself, is there an alteration in mental status? Those are the things I'm looking at when I am thinking cholangitis. When I'm thinking cholecystitis, of course, I'm looking at right upper quadrant abdominal pain, right? I'm looking at, does it radiate to the scapula? I'm looking at Murphy's sign. When I palpate this patient's abdomen, is there halting of inspiration? Those are the things I'm looking at. I'm asking myself, is the white blood cell count elevated? Is there leukocytosis? Right? When I'm looking at choledocholithiasis, which is gallstone in the common bile duct, I'm also looking at, is there right upper quadrant abdominal pain? Is there an elevation in transaminases, in GTT, in bilirubin, right? And in cholelithiasis, I'm looking at, is there right upper quadrant pain after they have eaten food, like greasy food? And is every other thing normal? So you see how you literally have to go through each of these cases because they can confuse you, right? And you pick out the subtle differences, and that's how you're going to stay on top of the game. All right? So we know this is choledocholithiasis. The treatment is ERCP with stone removal or stenting. Again, I got a question on this. In terms of complications, you want to watch out for acute pancreatitis as well as cholangitis. The imaging test of study, again, initial imaging is ultrasound. But you can do MRCP to help you come up with the diagnosis if you're still in doubt. Next, we have a 38-year-old patient presenting with difficult swallowing, right? There's difficulty swallowing solids as well as liquids. for the past 1 year. Something should be ringing in your head. This patient is not just struggling to swallow solid food, he's also struggling to swallow water, liquid, right? This has been going on for 1 year. He's also reporting regurgitation as well as unintentional weight loss. What is this? I'm going to give you a few moments to see if you can figure it out. Again, remember, the answer is always in the question. So patient is struggling to swallow both water and solid food. They have regurgitation and unintentional weight loss. Anytime you have an unintentional weight loss, that's not good. Now, if you're exercising or you modified your diet and you're losing weight, that's fine. But unintentional weight loss, that's a red flag. Okay, so the most likely diagnosis is what? This is Acalasia. How do you confirm it? How do you treat it? Let's find out. So the most likely diagnosis is Acalasia, which is incomplete relaxation of the lower esophageal sphincter and absent peristalsis in the distal esophagus. You're going to get a question on this. Guaranteed. Diagnosis can be confirmed by esophageal manometry. In terms of treatment, you want to do the first line treatment is pneumatic dilation. And then you can do things like calcium channel blocker. If those do not work, you can do injection of, you can do injection of botulism toxin, and you might have to ultimately do surgery if there's no improvement. But the first line treatment is pneumatic dilation. Next, you have a 30-year-old patient who is presenting with left lower quadrant pain, nausea, vomiting, and fever. You get a CT scan with IV contrast, and you are seeing a thickened bowel wall, and he has reported a change in bowel movement. What is this? How do you confirm it? How do you treat it? So there are two things. There are three things that are very critical in this case. One is left lower quadrant pain. Another one is fever. You get a CT scan, you see thickening bowel wall. This is diverticulitis. Anytime you see left lower quadrant abdominal pain and they have low-grade fever, the number one thing in your differential diagnosis should be diverticulitis. So that is what this patient has, diverticulitis. In terms of diagnosis, you can do a CT scan with IV contrast. I also got a question on this. What do you do in terms of treatment? It's important because this is an inflammation of the diverticulum, right? You want to rest the bowel. And when you rest the bowel, you want to give IV fluid. And then you control the pain. If all those things do not work, you do surgery. All right, next, 25-year-old patient presents with epigastric pain that has migrated to the right lower quadrant. Ding, 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 ding. Okay? He endures fever, anorexia, nausea, and vomiting. Palpation of the left lower quadrant elicits pain at the right lower abdomen. You get a lab study and it shows elevation of white blood cells, which is leukocytosis. What is this? How do you confirm it? How do you treat it? Look at the age. This patient is young. This is 25-year-old male or 25-year-old patient who is presenting with epigastric pain. So it started at the upper abdominal region and it now has settled to the right lower quadrant. There's fever, anorexia, they don't want to eat, right? And they're throwing up. Then you palpate the left side of the abdomen and you're getting pain on the right side. That's known as Rosving sign. This is appendicitis. Anytime somebody is complaining of right lower abdominal pain and they don't want to eat, they're throwing up, this is appendicitis. Most likely appendicitis. Okay? How do you confirm the diagnosis? CT scan. I got a question on this. The test of choice, the imaging test of choice is CT scan. Now, if you have a pediatric patient, you don't want to expose them to radiation. That changes your choice of study. You do ultrasound. And if it's a woman who is pregnant, you don't do CT scan. You do ultrasound. But ultimately, CT is the test of choice for appendicitis. How do you treat it? I also get a question on this. So, the treatment is you want to take it out, right? You want to do appendectomy, or you want to do antibiotics such as piperacillin, tazobactam, if you don't want to do surgical removal. Now, one thing you have to keep in mind, yes, you can be given antibiotics if you don't want to do appendectomy, but there's a high chance of recurrence. And I also got a question where it says, what antibiotics can you give if appendicitis is complicated? But when do you know that appendicitis is complicated? It is complicated when it's perforated, or when you see things like abscess. Okay? That's when it's complicated. Again, you can do a monotherapy of piperacillin, tazobactam, or you can do first or second generation cephalosporin and metronidazole. If they are allergic to penicillin, you can do clindamycin and fluoroquinolone. Okay? But the takeaway from this is that ultimately you want to do appendectomy to remove the appendicitis. Alternatively, you can do antibiotics such as piperacillin, tazobactam. Next, we have a 45-year-old patient with past medical history of appendectomy, and this patient is presenting with colicky abdominal pain for the past 5 hours. He's also reporting nausea and vomiting and has not passed stool for the past 2 days. You do a physical exam and you see diffuse tenderness and abdominal distension. What is the most likely diagnosis, and how do you confirm the diagnosis? How do you treat it? So let's go back to this case. This is a very interesting case. This patient has a history of appendicitis, which was removed. And later on, they are now presenting with what is described as colicky abdominal pain, and it's been going on for the past 5 hours. Poor kid. Well, poor patient. In addition to the abdominal pain, there's also nausea and vomiting. And very critically, this patient has not had a bowel movement in the last 2 days. You do physical exam, there's diffuse tenderness as well as abdominal distension. Guys, anytime someone has history of surgery, okay, you're reading the clinical case and you see that they've had surgical, they have surgical history in the past, right? Especially abdominal surgeries, and they are and you see things like distension, and it tells you that they have not been having a bowel movement. That means that some kind of obstruction is going on. All right, this is very important. So this patient most likely has small bowel obstruction, and the number one cause is surgical adhesion. So in this case, we see history of appendectomy. They are distended, they have colicky abdominal pain, and there's diffuse tenderness. How do you diagnose it? How do you treat it? So as I mentioned early on, The most likely diagnosis is bowel obstruction. You can confirm the diagnosis by doing an upright abdominal x-ray, and you're likely going to see dilated loops of bowel and air fluid level. And treatment, again, you're going to make these people NPO, nothing by mouth. You give an IV fluid, you place an NG tube, and you consult surgery. What is the most common cause of small bowel obstruction? I mentioned that early on is adhesion from prior surgery. Okay, and I also get a question on this. If you do an auscultation in a patient you suspect small bowel obstruction, what are you going to hear? And what is the most common cause of large bowel obstruction? Very important. So the most common cause is surgical adhesion in terms of small bowel small bowel obstruction. And when you listen on patient who has small bowel obstruction, you are likely going to hear high-pitched bowel sounds. I got a question on this. In terms of large bowel obstruction, the most common cause is cancer. All right, guys, my voice is beginning to crack a little bit, but we're almost done. So next question is, in Crohn's disease, what will colonoscopy show? So you suspect that the patient has Crohn's disease and you get a colonoscopy. What are you likely going to see? What is the initial medical treatment, and what is the treatment of Crohn flare-up? I also got a question on this. In terms of, you need to know, how do you treat Crohn flare-up? And what are the common complications of Crohn disease? Let's see. So you get a colonoscopy on someone in whom you suspect that they have Crohn disease, right? The colonoscopy is likely going to show skip lesions. And I'm going to make a video. Describing the difference between ulcerative colitis and Crohn's disease. Okay, so but colonoscopy is going to show skip lesions. You're probably going to see cobblestone appearance, and you're going to see something that is described as transmural inflammation. Okay, and when you get lab, you're likely going to see positive ASCA instead of negative P ANCA. This is very important. A lot of people confuse this. I used to. So in ulcerative colitis, it's going to be positive P ANCA. In Crohn's disease, it's going to be positive ASCA. Complications of Crohn's include anorectal fistula. That was a question in the exam. You're likely going to see things like stricture, abscess formation, and bowel obstruction. Initial treatment is salicylic acid, okay, such as mesalamine. And in terms of flare-up, you're going to do IV methylprednisone, okay, very important. I got a question on the flare-up of Crohn, so you need to know that. Remember that. So next, we have a 30-year-old male who presents with bloody diarrhea and abdominal pain, and this has been going on for 1 week. Patient is complaining of urgency to defecate as well as tenesmus. Okay, you do physical exam finding there's lower quadrant tenderness as well as anemia on CBC. What is the most likely diagnosis? How do you establish the diagnosis? What are the two complications of this condition? And what is the maintenance therapy when remission is induced? So again, there's bloody diarrhea. This person is not just having diarrhea, but it's bloody. There is abdominal pain, and they have tenesmus. Okay, tenesmus is when you feel that your bowel is full even after you empty it. And then there is left lower quadrant tenderness and anemia. This is screaming ulcerative colitis. You establish the diagnosis by doing colonoscopy. Okay, so this is ulcerative colitis. You establish the diagnosis by doing history and colonoscopy, or if you don't have colonoscopy available, you can do sigmoidoscopy. The two main complications are toxic megacolon as well as colon cancer. Again, I got a question on this in terms of the complication of ulcerative colitis. So once you have achieved remission, you can do a biologic, okay, such as infliximab. This is a very important question. And if it's now severe, you can do IV glucocorticosteroid. And if those things do not work, you can do surgery. And that's another difference between Crohn's disease as well as ulcerative colitis. In ulcerative colitis, surgery is curative. But in Crohn's disease, if surgery is not going to do anything. You know why? Because Crohn's disease affects anywhere in the GI tract. Okay? It's not limited to one place. So doing surgery will mean you have to remove the whole GI tract, right? But ulcerative colitis is not the same way. So that's why when you do surgery in ulcerative colitis, it is curative. So moving on, we have a 70-year-old male presenting with lower GI bleed described as painless bright red parectum. He has a history of chronic constipation and vital signs are normal. So look at the age of this patient. He is a male. He has lower GI bleed, and which is described as painless bright red parectum. He has a history of chronic constipation and the vitals are normal. That's very important. This sounds to me as diverticulosis. So guys, when you're taking an exam and it's telling you there's a lower GI bleed, first of all, the most common lower GI bleed is diverticulosis. So that should be in your bucket list of differential diagnosis anytime you read lower GI bleed. And look at the description. It is painless, it is bright red parectum. You need to underline that. And then this patient has a chronic constipation. And the vitals are normal. This is diverticulosis. So going into the exam, it is imperative that you make a distinction between diverticulitis and diverticulosis. So how do you establish the diagnosis? You want to do history and colonoscopy. And treatment is mostly supportive. It is important, I cannot stress this enough, that you increase fiber intake. In fact, one of the things you can do to prevent diverticulosis is fiber supplementation. Fiber supplementation. Next, this is a patient who is 8 years old, reporting that his father was diagnosed with colorectal cancer at the age of 40 due to familial polyposis. At what age should he be screened for colorectal cancer? I also get a question on this. According to the USPSTF, when do you start colorectal cancer screening in people with average risk? And what is the most common location for colorectal cancer? You are going to get a bunch of questions on colorectal cancer. So let's go back. This patient is 8 years old. His father was diagnosed with colorectal cancer at the age of 40. That's sad. And the reason being that he was found to have familial polyposis. Okay, that's a genetic problem that they have going on in the family, right? So now this changes everything. in terms of when you start screening this young male for colorectal cancer. So you want to start at the age of 10, okay? Because in the family, there's a genetic component of this in the family. So you want to start when this child turns 10. Right now they're 8. When he turns 10, you want to start screening for colorectal cancer. If he didn't have this, if there was no first degree family relative who had familial polyposis, then you don't start at the age of 10. That would be too early. So for someone with average risk, you start at the age of 45. It used to be 50, but they have dropped it to 45 because colorectal cancer is on the rise, unfortunately. Now, the most common location of colorectal cancer is sigmoid colon. Moving on, right? So this is actually where I'm going to stop at this time, okay? And again, I just want to reiterate, this is not exhaustive, but these are some of the interesting cases that you are likely going to see when you're doing your surgery clinical rotation. And the reason I concentrated these cases on the GI is very simple. 50% of those questions come from the GI. Okay? Followed by pre-op and post-op. Okay? So if you master the GI, pretty much you have nailed 50% of the end of rotation exam for surgery. All right? So I want to wish you luck. For those of you who are here to do your surgery rotation, I'm wishing you good luck. You got it. You can do it. I did it. Okay? You just have to make sure that you study every single day. It is very important. And depending on which surgeon you are shadowing or you're working with, they are going to ask you questions. Get ready. And one of the things I strongly suggest you do before you go in every single day, you want to talk to your preceptor, get a list of the cases that you're going to work on. Okay? If you are doing gastric bypass, which we did a lot of it, you want to read up on the patient. Okay? Find out what's going on with the patient. Don't just go into the operating room and not know anything about the patient. Why are they getting a gastric bypass, gastric sleeve? Okay? Why are they getting hernia done? You also need to know different kinds of hernias. Indirect inguinal, direct inguinal, femoral hernias, umbilical hernias, ventral hernias. You want to know those hernias. And you want to study the anatomy of the case that you're working on. I had my preceptor ask me a question to be able to describe the anatomy of femoral hernia. And I impressed him by knowing it. Okay, with femoral hernia, you need to know that it's inferior to the inguinal ligament and it protrudes through the femoral ring. When you sound like that, somebody knows you know what you're talking about. So those are things you can do to impress your preceptor. Okay? One of the things I struggled with was, being aware of the operating room environment, because it's easy for you to get contaminated, right? You wear your gown, you scrub in, you're supposed to be sterile, right? There is zero room for infection. So you can turn to your left or turn to your back or your right and you get contaminated. Now you got to ungown yourself. You got to scrub in again. You have to do it all over. And it makes sense, because you have patients that you're going to be cutting open, and you don't want them to be infected. So it's important that you know those things, right? Nobody expects you to know everything from day one. But I always tell people this: you cannot go wrong by coming with good attitude. Even if you're not a top student, come with good attitude. Show up on time. When you come in, greet people. Introduce yourself. I'm so and so person, coming from this school. Okay? Ask what you can do to help. And also know when to ask your surgeon a question. When they are opening up a patient, or when things are not complicated, right? You use your brain. When you're doing surgery, maybe there's bleeding along the line and they're trying to contain the bleeding. That's probably not the right time to ask a question, because they don't want any complication. They don't want to be distracted. So you pick the moment, the right time to ask a question. Okay, this patient that we're doing this on, why are we doing it? What are the complications? What do you worry about? So you read up on the cases a day prior. You come with positive attitude. I had a professor who always used to tell us, when you're doing a surgery rotation or any rotation, be the first to show up and possibly be the last person to leave. I know sometimes it's not realistic, because you got to drive a long distance. You also have to study. And that's something you have to be able to balance. At the end of the day, you're graded by evaluation by your preceptor, how you did during your rotation. But you also have the end of rotation exam that you have to pass. So you can go to the hospital and get 100 from your preceptor, right? You did everything right in the hospital, but you failed the end of rotation exam. That's not going to cut it. So there has to be a healthy balance between you being clinically competent, right, performing in the hospital, versus performing at the end of the rotation exam, because you need both. So that's it. If you haven't subscribed to my channel, I don't know what you're waiting for. I present vital piece of information about your health. This is by no means for you to be able to diagnose yourself. If you have any problem, go and see your primary care physician. But health literacy can only help in terms of making an informed decision. Because if you now know that when you start having right lower quadrant abdominal pain, you're throwing up, there's anorexia, you're probably saying to yourself, maybe I have appendicitis. Maybe I need to go check it out. I heard this from Patrick's video. So that's the goal of this channel, is to make you more informed, make you more health literate, which will help you make more informed decision when it comes to your health. That way, even when you go to the hospital, you know the right questions to ask. I used to have a professor in school. He used to say, if you ask the right question, you get the right answer. I know people always say there's no dumb question to make you feel better, but trust me, there's a dumb question. So if you ask the right question, you get the right answer. How do you ask the right question? By the information disposable within your disposal. right? The more information you have. If two people are asking a question, I can tell you which person out of the two knows more or has more information. The question is probably going to be more directed instead of being broad. I know it's a weird scenario or situation, but the truth is, the more information within your disposal, the more intelligent your question is going to sound. Right? If I just go and ask what is a hernia, right? Versus asking an indirect hernia, is it lateral or medial to the inferior epigastric? Wow, somebody is looking at me like, what? The preceptor is looking at me like, okay, he knows something. He knows the anatomy, but he just needs to figure out, is indirect inguinal, is it lateral or medial? So he has an appreciation of the location, what the anatomy is, but he just needs a little bit of direction and he's there. Versus, oh, what is a hernia? And they're not likely going to answer that question. You know what they're going to do? They'll send you to go and do research. Some of the surgeons will say, you tell me. Not because they want to be mean or they don't want to answer your question, but there's a little bit that they want you to do first before they will now start spoon feeding you information. All right, enough of this inspirational talk. So thank you. I hope you find this video very helpful, and subscribe to my channel. I'll be churning out more videos as much as time allows me. All right. Again, stay healthy, stay blessed. Thank you.